My name is Isioma Okolo. I'm an obstetrics and gynecology doctor, and today I will be answering the question, why do we keep talking about race in obstetrics and gynecology, by sharing reflections from my professional and personal lived experience. And I'll be doing this by taking you through four key areas. First of all, an alternative take on my conflict of interest, and then a distinction between race and racism, and then I'll share some reflections on some initiatives I've personally been involved with. And then finally, I will be ending with a call to action for you. First of all, my conflict of interest. For me, a conflict of interest goes beyond declaration of funding. It is a reflection of my positionality, a reflection of the position from which I view the world. Now, looking at me, you may see a Black woman in her 30s. What you may not see is a Black African woman, specifically from Nigeria, who has lived and worked in four different continents. You may not also see a cisgendered heterosexual woman who is married and non disabled. These are various aspects of my identity which have impacted my lived experience and the lens through which I interpret the world around me. So my positionality impacts why, how, and with whom I work as a researcher. My positionality is why I am talking about race. For our learning objectives, by the end of this session, you should be able to acknowledge that race is a social construct, not a biological phenomenon, describe the different levels of racism, understand that there is a link between differential outcomes for our workforce and our patients. And finally, commit to taking action against racism within your own personal and professional spheres of influence. Are you ready? Let's kick it off by some useful definitions. Now, race. Race is a social and power construct that dates back to the 17th century, where systems of oppression, including slavery, colonization, and eugenics, categorized human beings according to their physical features. White Eurocentric features were placed at the top of the social pyramid, and all non white Eurocentric individuals were deemed to be inferior. This is the definition of white supremacy. This artificial valuation of human worth resulted in and continues to result in differential access to resources. This valuation has an enduring impact on how advantages and disadvantages are accumulated across the life course and between generations. This is exactly how racism operates as a system. Now, to reverse this system, it is not enough to not be racist. We have to be actively anti racist. Now, what does this mean?
Racism dehumanizes.
We live in a racist world, and all play active and passive roles in perpetuating racism. The system of prejudice and discrimination based on the ambiguous social construct of race, backed by unequal and unjust power dynamics.
Racism is inherent to every aspect of our lives. It is woven into the fabric of society, and consequently, its effects interface with our work as research associates, fellows, and faculty at the Program in Global Surgery and Social Change.
Therefore, the absence of conspicuous racist action is not enough.
We must be actively anti-racist. We absolutely, unapologetically denounce our wretched racist system and its proponents without exception.
Racism systematically places higher value and opportunity in the hands of a specific race, and as a direct consequence, disadvantages another racial group.
It is the benefiting of one group to the detriment of another that has led us to focus on anti-racism.
The work of anti-racism is allied to that of anti-discrimination and the evaluation of inequities based on gender, sexual orientation, caste, religion, ability, tribal affiliation, or socioeconomic status.
However, given the distinct relationship of racism, colonialism, and global health, we in the global health community have a moral imperative to shine a bright light specifically on racism within our sphere.
Racism is inherently linked with colonialism. Our work in global health is rooted in colonialism, which provided power to white Europeans through subjugation and exploitation of others.
Colonialism subsequently allowed for the creation of the construct of race to justify the dehumanization of those the colonizers exploited.
This practice has lived on in global health through the racist belief that those same colonial powers possess medical knowledge that is superior to that of the cultures they denigrated. Consequently, global health is built on a foundation that, at its core, is antithetical to the principle of shared human dignity and respect. Affirming our commitment to anti-racism also affirms our commitment to being anti-colonial.
Academic institutions in high-income countries are complicit in and the product of centuries of historic institutional colonialism and racism with overrepresentation of white voices that are heard on a global scale.
We interact with a diverse group of international partners, but cannot truly be equitable partners until we acknowledge and address the place of power and privilege from which we operate.
To implement PGSSC's commitment to anti-racism, we will begin by confronting issues of racial inequity in 3 distinct but related areas. Details about our commitment to anti-racism in the areas of people, culture, and civic engagement can be found in the complete statement on our website.
There is no one simple action that will eradicate racism. Rather, it will take continued vigilance and sacrifice from the PGSSC to eradicate this brutal and evil institutional inequity.
The PGSSC team must be proactive in the anti-racism fight. We must ensure inclusivity in color, culture, and commitment to social justice at all levels.
This is the charge required to be an active agent of change. Without it, we do not stand a chance against the racist system so intertwined in our daily lives that we mistake it for normal. It is not normal, and it is not right.
How might this apply to our workforce? Well, differential attainment is defined as the gap in attainment in levels of career progression for different groups of doctors. It is essentially the difference in the rate of and ease of career progression across the life course of a doctor. It starts well before medical school, continues through undergraduate and postgraduate training, and persists even beyond consultancy. Within our specialty and across other regions of the world, race and ethnicity are prominent features in the literature around differential attainment. Regardless of their region of primary qualification, whether they are UK trained or international medical graduates, racially minoritized doctors experience higher levels of differential attainment. We see it in differential rates of exam failure, successful career appraisals, access to subspecialist training, referral to the General Medical Council, and opportunities for senior leadership roles as a consultant. Now, why is it? Well, the causes of differential attainment are multifactorial and difficult to pin down. They may relate to relationships at work, so for relationships with our peers and our seniors. They may relate to the curriculum with regards to its fairness or assessment and also recruitment. It may also relate to the hidden curriculum of medicine, things that some of us get to know but are never formally taught. It may relate to capital and people's perception of your knowledge or skills. This is influenced by cultural barriers, including language. It may also relate to psychosocial and identity factors, particularly with regards to the experience and threat of bias and stereotypes, the feeling of not belonging, and also what impact this may have on your well-being. Now, what is very important to pay attention to is the environments as well as the individuals who experience differential attainment. Now, to do this, we have to acknowledge that the experience of racism and discrimination are part of the lived experience of people who experience differential attainment, who are also racially minoritized. So now would be a good time to explore exactly what is racism. The best definition I've come across is by Professor Camara Jones, and she defines racism as the structuring of opportunity and or assigning of value based on a social interpretation of outward appearance. This is unfair and it disadvantages some individuals and saps the strength of the whole of society through the waste of human resources. I'll pause there because it is important to acknowledge that racism impacts everybody, not just those who experience it directly. There are many levels within which racism operates. It is a system and can be described at three different levels. The interpersonal level, which we commonly pay a lot of focus to. This is in relation to things such as racial hate crimes and racial slurs, or even more subtle microaggressions. The internalized level, which is where racially minoritized individuals internalize and accept the dominant negative narrative around their worth. This may lead to feelings of helplessness and hopelessness and an inferiority complex, such that people don't put themselves out there. This explains the phenomenon of imposter syndrome and also can explain why racially minoritized people may be perpetrators of racist actions. Now, the systemic or structural level of racism is less spoken about, and it is actually the most dominant form of racism. It is the system and the foundation of the other two. And it is omnipresent yet invisible. And the reason for this is that it is pervasively embedded in every day to day life. It is embedded in our law, in our policy, in our guidelines, in our education, in our research. It is embedded in our narratives, in our media, and so it is normalized. And it is normalized because it is founded on white supremacy, the belief that white Eurocentric beliefs, bodies, and capital are the norm, such that everything else is other and disadvantaged when it comes to access to education, nutrition, healthcare, as well as exposure to the criminal justice system or environmental toxins. So essentially, we have to think of systemic racism as a structural determinant of health and career progression. As a specialty, I would like to see us focus more on this level of racism because I believe it is ultimately what fuels the other two levels. Here on the left hand side are examples that are applicable within our specialty, taken from the RCOG e learning model on racism, also featured in a recent TOG article publication by the Race Equality Task Force. And you can access this by scanning the QR code that you see on your screen. Now, once we have acknowledged the definition and the levels of racism, we have to begin to connect the dots. In connecting the dots, we know that when it comes to our patients across the life course, from conception to subfertility to menstrual disorders to pregnancy to gynaecology and menopause, racially minoritized patients and service users undergo excess morbidity and mortality, as well as negative experience of accessing obstetric and gynecological care in the UK. As we have stated earlier, we also have evidence of differential career outcomes, bullying, GMC reporting, and leadership opportunities within our specialty. Now, is it possible that these two phenomena are entirely random? Is it actually logical to expect that we will shift the needle for our patients and their families without simultaneously addressing differential outcomes within our workforce? To me, that's a rhetorical question, okay? I think the answer is no. These two things are further manifestations of systemic racism. And to be honest, it is quite tempting to focus on perceived deficits within the individual, okay? When the real problem is within the system. Here on the left-hand side is a quote from a learner in the qualitative study, What Supported Your Success in Training? And again, this quote illustrates the result of this deficit narrative, which is that the problem is innately with the individual and the lack of critique of the environments which support career progression. This is similar to what was seen and summarized in the Birthrights Report with regards to evidence and themes relating to systemic racism and not broken bodies. In the middle here, you can access by scanning this QR code an educational animation which I have created, which explores the dangers of using race-based medicine or research. And this is an exploration of how melanin is not a risk factor. Race is not a risk factor. Racism is the risk factor that we should be targeting and including in our research, our risk assessment, and our algorithms. So go ahead and scan that and have a look at that video. So I guess the summary is that there is nothing broken about Black and brown bodies and minds. It is the system that is broken, and that is where we must place our energy to fix. We must begin to critically interrogate the systems that drive these differential outcomes and experiences. Wherever you find yourself, I'd like you to ask, how might systemic racism be showing up here? You should care about this, even if you don't feel directly impacted by it, because racism saps resources from the whole of society, not just those who are directly impacted. These are resources that we do not have. We all work and live in resource limited environments. The pandemic really exposed that for all of us. Addressing racism really goes beyond social justice and nice to do. It is an issue of upholding patient safety, providing high quality care, and ensuring effective resource allocation training for our workforce. It impacts all of us, not just people who are directly impacted by this. So for me then, once I recognized the scale and the importance of the problem, I sought out ways to engage in positive solutions within my personal and professional spheres. And I did this first by committing to learning about the history of the problem. I spent 2 years at Harvard doing a research fellowship. And in that time period, I participated in the co-production of an anti-racism curriculum. Following this, after competitive application, we were awarded a grant to design a digital anti-racism curriculum for surgical residents across Boston in the USA. And I was able to bring this learning home to the RCOG in my role as a representative on the Race Equality Task Force focusing on differential attainment. And finally, where I work, I am currently advocating for proactive, sustainable, and data-driven co-produced solutions for advancing equality, diversity, and inclusion amongst staff and patients. So I'd like to focus a bit on my experience with RCOG and also with Harvard Medical School. So I owe a very special thank you to the members of the Race Equality Task Force in Stream 2 who over the last couple of years have essentially become part of my extended family. A special thank you to all of them for informing and shaping my views on this very important area. Now, on our multiple Friday evening meetings led by our president, Miss T, as her trainees fondly call her, she would charge us with this question: how are we going to measure the impact of what we are doing? Now, this is a question I want you to always have when engaging in this work, because this is a question that I think will hold you accountable. So some of the activities that the Race Equality Task Force have been engaged with have centered around increasing awareness on the subject. And this has been done through various presentations at the Congress, webinars, QI meetings, some publications through the TOG and the Obstetrics and Gynaecology Reproductive Medicine journal, which can be accessed through the QR code on your right-hand side here. We have also spent a lot of time gathering information. This has been gathered through focus groups, through the regional workshops, through member surveys, through specifically surveying trainees in the trainee evaluation form and education supervisors. This has also been focusing on activities around working with stakeholders and members of other colleges and the JMC, And we've also focused on training and education and specifically developed an educational resource which can be accessed on the RCOG e-learning website, which focuses on an understanding of differential attainment and how to address discrimination and racism within the specialty. There's also been work done around implicit bias training of the examiners. And again, some of these e-resources can be accessed through the QR code you see here on the right. And with regards to specific interventions, through some of our activities, we have developed a disparity dashboard, which is similar to the maternity dashboard in terms of tracking differential outcomes for trainees. We have also designed a workplace differential attainment toolkit, and we have also secured funding to provide coaching specifically for BME members, i.e., racially minoritized members, and are currently in the process of designing training which focuses on psychological and cultural safety awareness. So, a lot of work being done and plenty more work in the pipeline. Now, one of the big exercises we engaged with was in the regional workshops where we traveled virtually to 12 regions of the country to learn about your experiences and solutions towards differential attainment, discrimination, and racism. And I'd like to highlight two things. This was a summary of some of the facilitators and barriers identified by our members and fellows. So some of the facilitators included data and clear targets, compassionate and inclusive, diverse leadership, training and education, safe and clear escalation pathways, multidisciplinary team involvement. So this involves not just obstetricians and gynecologists, but our midwifery, nursing, and aesthetic team members, clear supportive systems for the most vulnerable doctors. Barriers that were identified relate to apathy, burnout, low staffing, lack of awareness, lack of supportive leadership, and lack of safe spaces or fear and personal discomfort. So these are really important things to consider in your own personal and professional context when you engage with these efforts, as things that may trip you up, but also things that you can really lean into to facilitate positive change in this area. And here is a really interesting word cloud, which is essentially a collage of responses that we got from the regional workshops when we asked those of you that attended, in one word, what you were going to be doing to essentially level the playing field when it comes to differential attainment and discrimination within the specialty. And very prominent words were to do with awareness, training, challenging the narrative, being brave and calling it out, bias and discrimination training, and support systems, leadership. These were all prominent words that came through from you. And very rich conversations, which have been summarized and will be shared shortly with you in a report from the RCOG. I guess finally, what I want to touch on is some of my reflections whilst I was at Harvard. So, I think this is best summarized as multiple exercises in translating knowledge into practice. Now, I spent 2 years at Harvard completing a master's in public health, but also a research fellowship. The Paul Farmer Global Surgery Research Fellowship is a 2-year program specifically aimed at surgeons and anesthetists who want to improve the quality of surgical care in low resource settings. And the training essentially uses research to build and improve clinical practice, policy, equity, advocacy, and capacity building and leadership in surgical care. Now, I did this at a very, very interesting time. I did this at the height of the pandemic. And I did this in America shortly after the killing of George Floyd and the resulting resurgence of the Black Lives Matter movement. Now, what I experienced whilst I was at Harvard was a radical institutional reflection on its engagement in perpetuating inequalities and a subsequent commitment to positive change. This impacted their approach to the recruitment of fellows, faculty, and medical students, as well as the retention and leadership within the program. The anti racism curriculum was co produced, it was mandatory, and it was embedded within the training program and involved all levels of people within the program. It sought out global expertise from individuals in the global north and the global south. They collected feedback on entry and exit surveys. And then following this, we were able to obtain grant funding for to develop and pilot an anti-racism curriculum specifically for surgical residents across 3 different teaching sites in Boston. And through this, I learned how to use an approach using implementation science methodology to design, pilot, and evaluate the implementation and outcomes of such a curriculum. It was a very rich and rewarding experience. Other things I came across whilst I spent time in the States was this practice of equity M&Ms or ground rounds. So similar to how we would conduct clinical M&Ms or ground rounds, the focus instead of the clinical sequelae was on interrogating any complex social factors that could have related to equity or inequity, and including this in the discourse and in the critique and reflection and learning from the case. This was done in a very multidisciplinary way that really helped, I think, to embed the learning within the institutional memory and make it more sustainable. I also experienced and saw examples of an innovative approach to embedding EDI initiatives within the surgical examination and revalidation. And I also saw examples of how race and ethnicity were specifically used when performing significant adverse event reviews. And this is, again, a lot of learning to bring back to my practice here in the UK. So I'm extremely grateful to my friends and colleagues, many of whom I now consider family at the PGSSC, the Chan School of Public Health, and Harvard Medical School. You have been extremely instrumental in my personal and professional development in this way, and I will be forever grateful. Now, finally, in thinking about action, I again want to bring us back to this very important quote from our president, Dr. Rani Thakur. How will we know we are having an impact? Now, I think again, this speaks specifically to accountability. In your personal and professional sphere of influence, how are you going to hold yourself and others accountable? This is very important because I frequently get asked, well, what's the college doing to address differential attainment, discrimination, and racism? To which I respond, what do you mean by the college? Who is the college? Is the college just the leadership and the council? We are the college. I am the college. We pay our fees. The RCOG is a membership-based organization. The beautiful structures in our new venue at Union Street, they belong to you. They belong to me because we are the college. So I guess the question you should be asking me is, what are you going to do about it? And what am I going to do about it? And this is important because we have to recognize that real change happens on the grassroots. And we are the grassroots, those of us on the front line who are working in this space, interfacing with our peers, our seniors, our colleagues, our patients, and the service users. Real change only ever happens on the grassroots, supported by compassionate leadership. So the real change will only happen with you and me. And of course, our leaders have to support and nurture the ideas we bring forward. But Ms. Thakur is not going to tackle racism in your DGH. That's literally down to you and me. So now that we know that we are the ones that we have been waiting for, what are we going to do about it? Now, this is an important question. It is important because we are tired, we are burnt out, morale is low, we are short staffed, we are striking. Things are difficult. But hold on, we know how to do difficult things. We are a specialty of medical educators, clinical leaders, gynae-oncologists, fetal medicine experts, generalists, parents, athletes, artists, best-selling authors, award-winning academics. We fix things. We fix things at cesarean section. We fix things at operative vaginal birth. We fix things on our laparoscopy list. We fix things in difficult clinic consultations. So we know how to do difficult things. The question is, Do we want to? So, my top 8 tips would be: first of all, be curious. In the face of inequality or inequity, ask yourself, what else might be going on here? Is it just what is on the surface? Is it the individual or the environment? What are the hidden structures acting as barriers to progression or safe outcomes? Number 2, be kind. Life is hard, things are difficult. I personally believe it is important to assume good intent, otherwise, until proven otherwise. And we have to be brave to call out discriminatory behavior and label this as behaviors as opposed to traits, because behaviors can be changed whilst traits are harder to. So with behaviors, there are opportunities for change and growth. We have to be kind to ourselves and each other. Number 3, be anti racist. By this, I mean to consciously and intentionally acknowledge the racist structures that exist and act proactively to reverse them. In acknowledging, you might need to grieve. You might go through a cycle of guilt and anger or bargaining, whatever it is, but you must acknowledge, grieve, move forward towards action. Number 4, you must read widely. You must read about the history, the power, and learn about local support and escalation pathways where you work. If they do not exist, try and figure out who you need to speak to about creating these pathways. Number 5, do a power analysis. In whatever initiative or project you want to be engaged with, make sure you get buy-in at the grassroots, but you also need to make sure you know who the leaders are who will support you, where to get allyship from, where you will get sponsorship from, and also where you are more likely to get resistance. Number 7, build in accountability into every project, every report, every committee you're involved with. How will you know you are having an impact in this project, in writing this report, in attending this committee week on weekend? And finally, rest. Do not forget to rest. Things are hard, but we can do hard things, but we must rest. So, I hope you found this talk very useful. Here I am highlighting some resources which I have found instrumental to my growth. If you have to only look at 3 of these, I highly recommend you buy this book by Annabelle Suemimo, who is a sexual reproductive health doctor. This is a brilliant book which will change the future of healthcare if it gets into the hands of the right people. An excellent audiovisual resource on how to address implicit bias is accessed here, built by Harvard, Outsmarting Implicit Bias. And then finally, make sure you check out some of the RCOG e-learning. Thank you for listening to me today. Go forth and do good things.